Okay, we're going to go ahead and get started. Hello, everyone. My name is Jeff Donnell, and I'm President of Enterprise Health. You'll be glad to know I'm going to spare you the video portion today. You won't have to see me with my COVID beard and Rolling Stones t-shirt. I want to help join our panelists in welcoming everyone to the Return to Work roller coaster. And this is a webinar that's focused on the strategies that some of the leading corporations and health systems are planning, using, refining, and wrestling with as we all begin to return employees to the workplace at scale. We know this topic is extremely timely, as evidenced by the fact that at least just a few minutes ago, we had over 380 individuals who had registered to attend today's session. So we want to thank all of you for carving out time on a Friday during what we know is an incredibly hectic period. I want to start off with just a couple of housekeeping items. We've actually muted everyone except our moderators and our panelists on entry so that we minimize background noise. And we are recording this session, so we'll send out an email to everybody early next week with a link so that you can access the recording and feel free to share it with colleagues. Also, I want to point out that given the uptick in virtual conferencing use, we've seen a few WebEx glitches here and there over the past couple of months. Hopefully, we won't encounter any of those today. But I'm happy to report we have assembled an outstanding panel. It's a group of occupational and employee health experts, and these are folks that are our clients and our advisors. And we've asked each of the panelists to make some initial remarks about their return to work approaches, and then we'll have a Q&A session. If you have any questions as we go, you can submit questions via the chat feature in WebEx, and we'll get to as many of those as we possibly can. Joining me today to help moderate is Dr. Fikri Isaac. Fik retired from Johnson & Johnson a few years ago where he was Chief Medical Officer, and he now operates Well World Consulting and also serves on our advisory board. So thank you, Fik, for joining us today. And before we turn it over to the panelists, I'm going to quickly provide a little bit of context on our organization as well as today's topic. So if we were trapped on an elevator together, or better yet, on a webinar, and you asked me who Enterprise Health is, here's what I'd say. We are the only cloud-based health IT solution that combines occupational health and compliance, clinical care, and employee engagement, all on a single, interoperable, certified electronic health record platform, equipping enterprise clients and their employees for a healthier future. And we work with a number of blue-chip global organizations, government agencies, hospitals and health systems, all of whom operate their own on-site employee health clinics, and many of whom also provide employee health services to other organizations. And over the last 90 days or so, we've been collaborating very, very closely with our entire client community to rapidly respond to COVID-19. And we've been modifying our existing pandemic response, medical surveillance, case management, encounter documentation, employee engagement, and reporting capabilities, all to help our clients with their specific use cases, including things like travel, employee monitoring, testing, and case management. And we've all been working together at a breakneck pace, and not just with individual clients, but with clients as part of an overall collaborative group. And we've been really refining and tweaking on an almost daily basis as this very dynamic situation unfolds. And we actually took a lot of the functionality we developed with our clients for COVID-19, and a couple of weeks ago we launched a standalone COVID-19 monitoring application for any organization that could use it, because we heard that a lot of people were trying to manage their employee populations using paper or spreadsheets. And then during that same period, we also developed and rolled out new telehealth capability, which we were actually able to develop and deploy in just a matter of days. And of course, now our collective focus is on return to work. However, as I think we all know, return to work guidance is confusing at best. You've got organizations like ACOM, the CDC, the World Health Organization publishing guidance. Business leaders and the business media have their own take on how all of this should work. And then, of course, governments at the country, state, county, and city level are all contributing to the mix. And we're left to sift through it all and try to tease out a sensible path forward. Earlier this week, we published a blog post to promote this webinar, and I want to read the opening paragraph because I think it frames things up. And what we wrote was, planning for widespread return to work over the next few weeks and months is starting to look like a wild roller coaster ride. And unlike the permanent, well-maintained, and predictable path of coasters found at reputable amusement parks, this ride looks like a rickety, hastily assembled, never inspected atrocity erected by a pair of inebriated carnies with fourth-grade educations and aspirations that don't extend beyond the county fair circuit. Further, this unattractive attraction is likely to have loops, corkscrews, and long stretches of missing track. And unfortunately, that paragraph describes the situation that we find ourselves in today. However, we're very fortunate to have with us a panel of experts who are all very well educated, very intelligent, and willing to share their approaches and insights with us. And this group certainly doesn't pretend to have all of the answers, especially as every one of us on this webinar finds ourselves in a fluid, changing every hour of everyday environment. But we are going to hear about some very practical solutions that various organizations are pursuing. So with that, what we're going to do is have each panelist spend a few minutes kind of telling us what they're up to, what they're wrestling with, and then we will open it up for questions. And leading off for us today is Dr. Peter Lee. Peter is the Global Medical Director at General Electric. He also does consulting work with Boston Medical Center and other organizations. And he's actually been dealing with the coronavirus outbreak on a global scale for months before it was even labeled COVID-19. So Peter, if you could open things up for us.
Thanks, Jeff. Hi, everyone. Appreciate the intro there, Jeff. So I'm going to just spend a few minutes, really targeting sort of the global perspective around the COVID-19 response. GE is a large company. We operate in many parts of the world, and have over 200,000 employees. And so hopefully, my comments will share some insights with other global representatives on this call, as to sort of cross-learn and think about how best to manage it on a global basis. Okay, so this has been a fascinating experience, to say the least. For us, we very rapidly had to address the issues in China as the the pandemic started to happen, centered around Wuhan and then spread throughout China. And one of the interesting dynamics here is that we then got to see how our colleagues in China sort of unwound everything that was put into place to address the outbreak, and hence getting people back to work. And so one of the first things I want to share with everyone on the call is that it is possible to get everyone essentially back to work. Okay, we've clearly seen it in China. Our operations that had to be shut down due to the government directives are all up and running again. Okay, and so in China, they took a unique perspective in that they essentially looked at every province, city, town, if you will, and then they risk stratified each of them into low risk, medium risk, high risk. And so high risk is there are more than 50 cases, or there's a community transmission or local epidemic, or you're seeing clusters of cases. In the medium risk, there's less than 50 cases during a 14-day period, and only sporadic cases, no clusters. And then the low risk is the absence of new COVID-19 cases for 14 days. Okay, and so you know, we follow the Chinese government's directives to, throughout the country where we had operations, and you had to meet, all the way down to the low risk before, things can open up. And so, as each of us, helps our companies and corporations think through return to work, one of the first things to do is, think through the risk profile that exists in the community in which you operate, right? So here in the U.S., it's probably going to be a little bit different in terms of how we respond in New York City versus how we, respond in, Aspen, Colorado, right? So think through that, and definitely, follow all the regulatory demands that exist, both, from a country level down to maybe province and state to the city and towns. And because we in this case, now that we're dealing with this massive pandemic, the government is all involved, and it's got some very interesting downstream impact for a company like ours. So I'll share really quickly a few lessons learned for us. Okay, so we always follow the government directives, but let's use temperature screening as an example. So in China and in India, they set, across the country, the definition of fever is actually 37.3 or 99.1. Here in the US, the CDC has a definition of fever of 100.4, but then they also have a surveillance definition of fever of 100, right? When we went, then we have operations in Ohio, and when the governor of Ohio requested, proposed his plan for employers, he used 100.4 based on the CDC's guidelines. But then, the mayor of Dallas, who then recommended his proposal or the direct executive orders, used 99.6. So and on top of all this, we actually, 4 months ago, already had agreement on what GE's definition of fever would be. And so one of the first lessons learned here is, you need to have a definition for your teams to work with, but you need to, each of us need to allow some flexibility to meet the regulatory demands. In some places it'll be country specific. In other places it may be down to, the city or the town. Okay. And, probably, like us, you have lots of very astute employees, and everyone's trying to do the right things. Don't forget to make it very, very clear whether you're trying to say equal to and greater than, or just greater than. If we don't have that clarity up front, once your guidance gets out in various documents, it can be very challenging to clarify that issue. And obviously there are downstream, consequences, right? So let's say we're dealing with let's say we set up temperature screening at one of our facilities, and someone's at that exact temperature, and maybe you have to deal with employee population that's union based. That one degree can cause a big difference in whether someone can work or not. And so it's really important to be very, very clear on how you want to roll out these types of actions for the company. I'd also quickly say that having site leadership is really important. We're taking a very we're having each site meet various criterias and standards that we've put into place, and we need someone that's accountable at every site to also drive all the actions that we're putting into place. And I really recommend that appointing someone to be in charge to make sure that all the items that are in the metrics and the checklists are done properly, and as well as getting the communication of new information, of updated information is key. As all of you know, our understanding of SARS-CoV-2 is constantly evolving. And so our understanding of the therapeutics and, even vaccines, maybe a year or two from now, will need to be rolled out appropriately as well. Okay. So make sure those two things are in place. And then I would just, lastly, think about site preparedness. You may want to do a lot of different things like, making sure there's enough space, 6 feet apart from, desk to desk, maybe shutting down fitness centers, cafeterias having only, take to go meals or the seats need to be at least 6 feet apart. Also thinking about maybe, having, hand sanitizers more available for employees or requiring, face protection, right? And face coverings and PPEs or thermometers. There's a real challenge at the current moment in terms of supply chain for the material. And so it's really important that once the plan is set into place, to very rapidly work with, reliable suppliers to get all the equipment and supplies that's needed for all the sites, around the globe. I think one last thing, before I hand it back to you, Jeff, is that we also learned just how important data management is. COVID-19, what's so unique is that I think it's such a dynamic process for the employee/patient. So, while we have really great ways of categorizing, where our employees fall, which categories our employees are in, right? So they've been tested and confirmed to have it, or they're presumed to have it based on a clinician's diagnosis without testing because testing wasn't available. Someone may be a close contact, of a confirmed case, hence there's, suspected to have COVID-19. Each of our employees will migrate from category to category over time, right? And, the amount of time it takes for someone to reach some sort of disposition status is also going to vary. And so, we can have an employee that gets, rather sick, requires hospitalization, and they may be out for a couple of months, while others may, just be out for 14 days. And so, it's super, super important to have some, system or, technology platform to be able to capture the data. But in this case, not just capture, but be able to maneuver, the data as the situation changes for each of the employees. And lastly, if you're going to do this work on a global basis, or if you have to do this work on a global basis, pay very, very close attention to the data privacy laws around Europe. In particular, it hasn't been easy for us, in France and also in Russia and the CIS states. There are just some very particular data privacy laws that requires some expertise to navigate, and it's not out of the realm of possibility to need to carve out another approach to being able to provide contact tracing or provide data management. Okay. So with that, Jeff, I'll turn that back to you. That's sort of where we are. The little bit of the insights from the journey that we've been on for the last few months.
Great. Thank you so much, Peter. That was very helpful. Next up, we have Dr. Al Rielly. Al is the Medical Director of Occupational Health at Mass General Hospital. and he's going to be able to provide us with a little bit of the health system point of view. Al?
Thank you very much. So as many of you know, sort of COVID is evolving all the time. So we're using an algorithm-based approach to our employees' return to work, but we've had to modify it over time. We're using a test-based strategy with PCR with the nasopharyngeal swabs. And we were finding that we were getting employees, even though they no longer had symptoms, it had been a number of weeks, we're still testing positive. So a few weeks back, we had altered our algorithm to what's in line to what the CDC just came out with last night. So to step back a little bit for our employees, what we're doing now is there's an app-based or computer-based, they have to log in before every shift and they ask about questions about symptoms for COVID and any temperature, and they have to answer all the questions. And if they answer all the questions negatively, then they sort of get an email message that they show at the door to be allowed into work. If they have any symptoms, they can't go to work, it'll be flagged, and then be followed up to determine if they need additional testing. Also at the work site, basically you have to wear a mask at all times within the clinical facility. Our algorithm is, again, a test-based strategy. So what we're doing is if someone is symptomatic with confirmed COVID by PCR, we're waiting until they're at least 10 days from the first test before we'd even consider testing again. They have to have resolution of fever and all respiratory symptoms. We're requiring 2 negative swabs at least 24 hours apart. And if it returns positive, we're waiting at least 5 days to test again. What we're also doing, if someone in our community, people are starting to be offered testing even if they have no symptoms, and we're seeing employees who have always been asymptomatic, and if they have a positive test, we're managing them as if they were positive, so we're waiting at least 10 days after they were initially positive, and if they have no development of symptoms, we're returning them to work after 1 nasopharyngeal swab. What we're also starting to do is do some validation of some of the ELISA serologies. The city of Boston has asked Mass General to do community testing in some of the hardest hit areas. In addition to that, we're doing serology testing on asymptomatic employees just to get an idea of the prevalence. Again, we're doing a test-based strategy right now. I think as the science gets a little better, what we'd like to do is kind of move into perhaps making use of some of that serology, but it's not there yet, at least for us. I think one of the big issues has also been in terms of contact tracing, because we still are managing and tracing some of the employees that turn positive, and we're seeing some workplace issues, which I think will become important as we try to scale back up to return to work. So for example, even though there's a mask policy for all employees when they're in the facility, what people were doing, they were going into break areas and they were eating lunch together. And we found a number of clusters that way where someone who was asymptomatic took off their mask in the break room with other employees, and those other employees became infected. So we're finding that we have to also alter kind of the workplace practices as well. I think in Massachusetts, the cases haven't really started to decline yet. We're kind of plateaued. So I think for us, it's a little early to really start scaling back up. But I think hopefully with the social distancing and some of the improved testing in Massachusetts, as the cases go down, then I think we're going to start to see how we're going to scale up. We've done a number of redeploying of employees. A lot of employees are working from home and also doing telemedicine visits. And that's been a change for a lot of the providers to get used to. But I think as things start to improve a little bit, there are a number of clinics that we'd like to have people go back into, like orthopedics, even occupational medicine, where we are doing employee health. We've really kind of limited replacement visits. Also, some of our DOT and OSHA surveillance, like spirometry, has been put on hold. So I think as the cases start to improve, then we're going to have to start to see about how we're going to scale that back up. But again, I think it's still changing right now. I'm hopeful that serology might be able to provide some assistance, but for right now, we really don't have enough data to really make positive changes right now.
Okay, great. Well, thank you, Al. And yeah, it's really interesting, your comments about, about making workplace changes and, for example, realizing that behavior in the break room is contributing to issues. And I suspect that all of us are going to find that that's the case, and we'll have to make adjustments on the fly. Well, thank you again, Al. So next up, we're fortunate to have actually two individuals with us from Phillips 66. We have Tim Raycob, who is a physician assistant and director for medical compliance and policy, as well as Dr. William Parsons, who is the chief medical officer. And they're actually on the forefront of antibody testing for their employees and have some really interesting data to share. So Tim, let me pull up your slides here real quick.
Thank you, Jeff. Let me start off just by giving a little background here. In mid-March, Dr. Parsons and our executive leadership wanted to determine if there was a way for us to start testing our employees to ensure their safety and well-being at the workplace and make sure that we were not having potentially infectious people come in contact with naive employees. And around that time was when Abbott came out and FDA announced that they had approved a emergency use authorization for their new reverse transcriptase PCR point-of-care test. And Dr. Parsons and the rest of the health services leadership got into a little bit, we discussed it, and we decided at that time that it was not really an appropriate test. Really the guideline is that you should only be testing symptomatic employees. We did not want to be bringing potentially infectious employees who may have been asymptomatic into the workplace to test and expose our healthcare providers. And so at that time, we decided we needed to look for something else. Around that same time, we found that FDA had also approved a EUA for some serology testing. So we looked into that. And around April 6th, April 3rd, we found two companies, one based out of Colorado, one based out of Canada, that had serology tests available. We contacted them and ordered some serology tests. We ordered 8,000 from the company in Colorado because they had them immediately in stock. And then the company out of Canada, we actually have a rolling order in place to get 2,000 to 4,000 tests every 2 weeks from them. We then work with our legal department to set up a consent program, and then the health services group developed a protocol and policies and workflows on how we were going to do IgM, IgG testing for our population. And so on April 15th, we got final approval from legal and our executive management team, and we started testing our population. Next slide, please. So this is the results of our antibody testing since April 15th. And these numbers are actually off. These numbers were run around 10 o'clock yesterday morning. So they're off by about 100 tests. But as of yesterday, we had run almost 1,400 tests. We had 8 come up IgM positive only, 20 come up IgM and IgG positive, and 20 come up IgG positive only. So that equates to just about 3.5% of the tested population, which interestingly is very much in line with the numbers that Stanford got when they tested the Santa Clara population in California. So it kind of shows that our population is pretty much in the same exposure rate. the curious thing, or the interesting thing, is that 30 of the 48 cases that came up positive came from 4 sites, all of which are considered hotspot sites. When you consider that we're doing testing at 26 different sites, and that 4 sites are accounting for over 60% of, or 65% of our positive results, it was just kind of an interesting finding. So one of the things that we decided when we initiated this serology testing is that we needed a new encounter built out in enterprise health to help us not only document our findings, but be able to run reporting metrics off it. So I'm sure, you know, this is just a small screenshot of our part of our dashboard. So one of the things that we asked Enterprise to do was build out what we call an antibody visit. And it's one of our portlets, just like, you know, I'm sure many of you have similar portlets. But when you click on that antibody visit, it takes you to a screen. Next slide, please. And what we have is a standard procedure that you select. That's a COVID IgG IgM rapid test. It comes in a cassette form. There's 2 little, it's a colorimetric filter paper test with a control line at the top, and then a G and an M to show what the which antibody was present in that sample. And then the test date, you know, just your usual lot information. So if you look at that COVID-19 antibody result, you'll notice that there's 5 radio dials that you can select. The negative one, if you select it, it says pretty much that you have no antibodies in your system. You're eligible to be cleared to return to work, you know, maintain social distancing, facial coverings, good hand hygiene, etc. If you test positive for IgM only, it says that you have to home quarantine for 7 days or until asymptomatic for 72 hours without the use of medications. And then you'll see employee instructions. Those employee instructions are automatically sent. We can either print them out right there while the employee is on site, or it can be sent directly to their employee portal and they can access those instructions. If they're positive, they're told to immediately go home, start self-quarantine, contact a primary care provider, and get a confirmation PCR test done. And then when they're done with their quarantine period, they have to be cleared not only by their primary care provider, but they have to be interviewed by a Phillips 66 healthcare provider before they're allowed to return to the workplace. Next slide, please. So you can see there, this is someone who's IgG, IgM positive. And again, the employee instructions, which are very similar. We know that if you're IgG and IgM positive, that, you know, we don't know exactly where you are in the infectious stages. Are you a mid-stage infection? Are you a convalescent stage? Because if you're mid-stage, you're most likely still capable of transmitting virus. And so they have very much the same directions as someone who has only IgM positive antibodies. Next slide, please. And then if they have just IgG, it says you have full antibodies and are potentially immune to COVID-19 and may be protected. You don't need to take any further action, and then they're advised to maintain the standard CDC recommendations regarding social distancing and facial coverings. So I think what it shows, you know, we're testing our population, and we're not doing it so much as to try to find active infectious cases. What we're trying to do is find out what percentage of our population may be infectious, may have recovered, but more importantly, what percentage of our population is still naive and therefore still susceptible. And then how do we develop a plan to protect those naive employees so that they can continue to work as we are considered a critical infrastructure. And that's really what the testing program is designed for. And that's all I have, and I believe Dr. Parsons is next.
Good afternoon. Actually, I don't have any slides to tell you, but as far as on the antibody testing, we did make it completely voluntary, and that it was basically for informational purposes for the individuals, and we had great reception for it. We did, of course, start it in our refineries. Approximately 70% of our employees in the U.S. were labeled as essential employees and still work their jobs during this lockdown periods at various sites. The rest worked from home. And of course, we had a handful that were placed on short-term disability because of underlying health problems. As far as what we have done getting our people back to work, we have large populations in both Oklahoma and Texas, which have stopped their lockdown procedures. And we are planning to reopen our offices in phases starting May 4th, both in Oklahoma and Texas, where we have approximately 4,500 people that are in office type facilities or research facilities. And we're going to do that in phases over a 4-week period, with hopefully full back to work right after Memorial Day. This has been received pretty well. One thing, on many of our millennials, they do have childcare problems. We're letting them work with their supervisors and giving them to come opportunities to come in later in the month. And also, we are getting lots of emails regarding possible health problems that would push them back. And we're using the CDC list of possible complicating factors for COVID. Overall, though, our people are very much wanting to get back to work. And as I say, 60-some% of them have already been working on a daily basis. We are offering the antibody testing basically to our operational people. On the office-based people who can work from home, the antibody testing is really only being done on those people who have a history of possibly having, possibly having the disease. With that, I will turn this over because I believe there's other people that need to talk.
Thank you very much. Thanks, Tim and Bill. That was great. All right. So last but certainly not least is Amy Adolay. And Amy is Labor and Employment Practice Group Chair at Krieg DeVault, which is a law firm that specializes in occupational and employee health, among other things. So Amy?
Thanks so much, Jeff. Thanks for having me as part of today's discussion. Certainly over the past week or so, we have seen the discussion quickly pivot to these return to work issues and planning for this next phase of the COVID-19 pandemic. I will say that we are already seeing an increase in OSHA complaints from employees who are back to work already, and claiming, whether correct or incorrect, that their employers are not following CDC and OSHA guidance. So I just want to cover, from a legal perspective, a few things as far as considerations as employees return to work and the issues that are cropping up as that occurs. One topic I'd like to cover is just the healthcare providers' notes that employers are requiring. One thing I would note there is to check your local and state executive orders and so forth. Sometimes those executive orders are actually prohibiting employers from currently requiring return to work notes. So, while in normal times, it's something that we require under sick leave policies and for various types of leave, you may have a local or state directive that's currently either suggesting or prohibiting you from requiring those as it relates to COVID illnesses. But a couple of other topics there on providers' notes and where we are seeing them, several different types of situations. One, as several have talked about today, where someone has an underlying health condition that makes it more likely that they would suffer, a serious illness if they were to contract COVID-19. Employees are looking for notes on that from their providers to provide to their employers, because now that they're being asked to return to work, they need to request reasonable accommodations. So those notes must indicate that, due to this underlying medical condition, it's medically necessary for that employee to have a particular accommodation. The other area we're seeing requests for notes are certainly if someone's under your care for a COVID-related illness, and much of the time, return to work dates aren't currently available. I would encourage all organizations that are caring for patients and developing those notes to come up with a standard note in that circumstance that's going to be provided to all patients. I've seen a lot of clients doing that as well. Next area where we'd see notes is, where you're advising someone to self-quarantine, or, somebody's experiencing symptoms of coronavirus and seeking a medical diagnosis. So these notes are going to come into play as people go back to work and may begin requesting leave under the Families First Coronavirus Response Act. I think we'll see an uptick in those requests now that employers are reopening, employees are being asked to go back to work. Next area I'd like to quickly cover is an issue that several others have talked about as well, relating to monitoring employees and the ability of employers to ask medical questions and require medical examinations. So first of all, under the Americans with Disabilities Act, employers can ask medical questions and can require medical examinations, but only if those questions and examinations are job related and consistent with business necessity. The EEOC has said, employers, you can meet this standard where it's necessary to exclude an employee who has a medical condition that would pose a direct threat to the health or safety of themselves or others. And they have clarified COVID-19 is certainly one of those situations now that it is a pandemic. So yes, you employers, you're permitted to ask about symptoms. You're permitted to ask about travel. You're permitted to take temperatures, which are considered a medical examination under the ADA, given that this is currently a pandemic. Last week, the EEOC finally came out and said, yes, employers, you can also test or have mandatory testing requirements for COVID-19. So there was some question lingering as to whether the EEOC would approve mandatory COVID-19 testing, and they have said, yes, you can require that your employees be tested for COVID-19. I think the antibody testing is fascinating, and I've really enjoyed listening to Tim, especially talk about it last week on the webinar. You know, and as we've heard, you know, Phillips 66 is making this the antibody testing voluntary, not mandatory. My guess is that part of the legal team's reasoning in that was, you know, would this be a permissible mandatory medical examination in the eyes of the EEOC? I think it's possible that as we move forward in the next few weeks, we'll get some additional guidance on that from the EEOC, because it's certainly, you know, a direction where employers are moving towards and looking to get more information, and therefore, you know, could we require antibody testing in an effort to figure out, especially, you know, who is still susceptible. So I think we should have our ears peeled for more information from the EEOC on antibody testing. Finally, I'll just mention a few other issues I'm seeing as employers plan for the return of employees or more employees. You know, first of all, they're developing their written plans or finalizing them or tweaking them if they already have them in place. Many are just now finalizing those written plans. You know, they're incorporating the White House's Opening Up America Again plan and its 3 phases. As I've pointed out to several clients, you know, you'll see the CDC logo right up in the corner of that plan. So it's certainly something that employers should be considering as they're developing their own plans, and considering the CDC and OSHA guidance, and also taking into account state and local requirements. You know, also keeping in mind that if you're not following, you know, that federal guidance, then you're opening yourself up to OSHA claims, workers' comp claims, et cetera. You know, under OSHA, there being this obligation to create a safe workplace, you know, duty, an affirmative duty to create a safe workplace for employees. Another issue that's popping up is employers who have employees who don't want to come back to work. What I have been advising employers is that you need to take the next step and ask that individual why. What is their reason for not wanting to return to work? It's possible that the answer is there's an underlying health condition that makes them, you know, more at risk, and therefore the employer may have an obligation to accommodate that employee. It may be that employee is afraid that safe practices haven't been put in place in the workplace to keep them as safe as possible. And so it may just be a matter of educating those employees on the steps that have been taken to create a safe workplace. And really beyond those issues, you know, that individual is not really protected simply because they're afraid to come back to work. And so employers are having to wrestle with, well, what decisions are we going to make if we have these groups of employees who don't have a legitimate lawful reason not to return at this time, but are just afraid of contracting COVID-19. You know, we're certainly getting clarification from unemployment systems that, you know, those individuals who are simply afraid to come back to work are not going to qualify for unemployment. At least that's the position of most states. On the topic of unemployment, you also have employees who are saying, well, I don't want to accept, you know, that work you're offering to me or those hours. I'm just going to stay on unemployment. Issue there is certainly if you have work available to them, they need to be taking it. Otherwise, you know, for you, the employer, to allow them to continue to collect unemployment in that circumstance, you know, you, the employer, are committing unemployment fraud. So also not a workable solution. Final thing on return to work is, as others have said, just making sure that when employees do return to work, you're enforcing these rules and standards that you've spent so much time putting into place. Because, you know, if they're not enforced, then, you know, not only are we going to have increased spread but we're going to take, then steps backwards, which still may be necessary in terms of retreating from reopening and so forth. But you also, as I mentioned earlier, run the risk of increased OSHA claims, workers' comp claims, potential third-party liability claims, if you're not then enforcing, these practices that you've spent so much time putting into place. So making sure, really taking a firm, hardline stance on those. And with that, I'll turn it back over to you, Jeff.
Okay, great. Thank you, Amy. That was wonderful. And again, thanks to all of our panelists for sharing with us and being so open. We're now going to turn it over to Vic Isaac to facilitate Q&A with our panelists. We've got about 20 minutes or so remaining. We'll go until about 2:15. And remember, you can pose questions using the chat feature in WebEx. Vic?
Thank you, Jeff. Yeah, what a fascinating discussion and really great input from all the panelists, looking at it from multiple angles as it relates to the crisis we're in. I'm going to basically try to, pose a couple of questions, and I'll call who on the panel, since we're all virtual here. And then hoping we will also have some time at the end for the audience who are joining us to ask the questions, and we can answer them. It would be great. If not, again, as Jeff said, we'll follow up. My first question, goes to actually Amy. What about the potential and or the process as it relates to, workers' compensation? We heard few from the panelists related to the fact that, they noticed some clusters within their facilities or within the workplace. The question is, did they bring it from the outside? Is it from the inside? Asymptomatic people versus not. What is your advice on that?
Yep, so a few things, and really this is going to vary state by state. We are seeing some states change their workers' compensation laws to make it very clear that there may be coverage for individuals who contract COVID-19 in the workplace. Other states are not changing those laws. Obviously the question there is, well, can you actually, or how accurately can you trace that infection back to the workplace? And that would certainly be the debate in any of those workers' compensation situations. And maybe that someone could say, the only place that I came in contact with an infected person is through work. Other than that, I haven't gone anywhere, just all of those factual considerations. The other thing, that we're seeing is, it may be more likely that someone who is working as a first responder or working in healthcare will have a greater success of, establishing that contact, tracing that contact back to the workplace. So it's certainly not out of the question that some individuals will be able to successfully obtain workers' compensation as a result of COVID-19. One thing I would encourage employers to do here on the front end before those issues start coming in is to reach out to your workers' comp carrier and have this discussion about what is our approach going to be when we get one of these claims in. Are we going to presume that there is coverage, et cetera? So reaching out to your workers' comp carrier and figuring out a plan before these issues come in, particularly given where you're located, what state you're in and what your current workers' comp law might be.
Thank you. I'm going to move fast as we do have limited time, but this question is for Peter. What a story about the global application and the diversity of the approaches that you are facing between countries. But I want to bring you down to the U.S. As you plan next phase. You mentioned earlier about the risk stratification that was followed with the number of cases and the guidance. How are you going to apply that here in the US? Do you have a system? How are you tracking those numbers to say it's 50 cases or more, or clusters and all that? Do you have a system in place that could monitor and track? So that's one quick question. And the second one is, who is really in charge of, who makes the call at the end of the day, whether, this operation is low risk, medium risk, or high risk?
Okay, so thanks for the great question. In terms of what we're doing in the U.S., again, my employer, always follows the law, and we try our best to, keep on top of it. In this case, it's a little challenging, as described, given there are 50 states. But look, what we did, or what we are continuing to do, is we know where our operations are, right? And so it's not like we have to track every state and every city. We are paying very close attention to any regulatory guidance or directives in places where we operate. And so much of our risk stratification actually starts by being a good partner to the government, whether that's at the state level or country level, or down at the city level. What was the part two?
Yeah. The second question is, who would be making the call within your operation organization? Is it a business continuity planning? Is it who makes the final call?
Yeah. So we're so fortunate that we have an incredible head of human resources, and he's very operational, very detailed. And what he did early on was, establish, essentially our task force, our COVID task force, and we pulled in experts from the various functions, like communications, environmental health and safety, security, obviously, medical, and this collective group, we meet, initially early on, we were meeting daily to, drive essentially guidance that's applicable, throughout the entire globe. And so we've set standards for each of our site leaders and businesses to follow. Now, at some point, right, we're not going to. It's always a balance. We don't want to overburden, our businesses, our manufacturing plants, but we feel that it's extremely important to have a consistent approach across the entire company. And so, I'll give you an example, right? Like we talked a little bit about temperature screening. While we will dictate, what were we gonna set as the temperature cutoff, we're not gonna sit there and say you need to use X, Y, and Z brand of thermometer, at all the sites. We're just not gonna do that. We realize that the sourcing process is gonna differ from sometimes from businesses to businesses, and sometimes very often from country to country. And so it is kind of a fine dance between what we want to say have to do, and then allowing some room for the sites and the businesses to decide how to go about doing it. But
thank you, Peter.
Yeah.
Now I just want to ask actually a question for both Al, from a health system perspective, and what a fascinating approach you are applying within the healthcare system with the different protocols and the algorithm followed, but also to Dr. Parsons and Tim, as it relates. I think Amy mentioned the issue of fear. So from a health system perspective, we know and hear about burnout within, the healthcare providers and service delivery aspects. And then certainly in workplaces, the concern and the fear of what is coming next or not. And my question to both of you, and maybe we'll start with Al and then we'll follow with Bill and Tim, is how are you supporting your employees and their families as you go through this very stressful, unresting times?
Thank you very much. You're absolutely right. Employee well-being is very much a big concern. I know when I'm in the call center, sometimes talking to employees, I get a lot of those questions. You can see many people have fear about themselves, about their family. I know some of the things that partners have done. They have resiliency groups that people can participate in. They also have mental health webinars. One of the facilities that's affiliated with Mass General is McLean Psychiatric Hospital, and they've done some great webinars, some of the psychiatrists there. And they also are using some smartphone apps that were clinically vetted, like Headspace and Evermind. Just, I think that the main thing is educating and communicating with employees. Every day there's sort of an email that goes out kind of listing what's been going on, resources. And then also for employees that may not be able to access email, they also have texting on the phone if people want to participate, where they will get daily updates about what's going on, and also resources that they can access if they choose to.
Thank you. And maybe we'll hear from Tim and Bill. What are you doing related to the population that either are back to the actual workplace or working from remotely?
Okay. Well, of course, as I had said before, about 65% of our people are working still in the refineries and the pipelines. And basically, they are doing business as usual. We do have a couple of hot spots. We do have a refinery in Linden, New Jersey, and we have one just south of New Orleans. We also have 3 in California. It's kind of interesting on the antibody test. The first thing we did is test all the healthcare workers, and I've got about 34 of them. And all were naive except one nurse practitioner in California who was IgG positive. So we've done pretty good, I feel, as far as keeping up our sanitary protocols. But again, we do have EAP services available, both internal and also a contract with Aetna for family problems. And I've been a little surprised that they haven't been used as much as I would have thought. The people who are working from home seem to be doing quite well. In fact, we're having a little static on them, trying to get them to come back to the office. But in our industry, people do know we're making a product that needs to be used, and most of our people are very well paid. So the unrest really has not been there.
Very interesting. Great to know. I can certainly keep going. I have so many questions to go through, but I think I'd like to take a few questions from the audience at this point.
Yeah, that would be great, Vic. Thank you so much. On the heels of the last question, actually, I think Dr. Parsons and Tim, you'd be great to take a first stab at this. There is a question on liability for the antibody screenings. If they're not accurate, if it turns out that they're not accurate, what type of liability have you been advised of there? I think Amy could certainly, chime in on that as well. But for Tim and Dr. Bill, what have you been hearing from your teams on sort of liability there on the antibody screening?
Well, we make it very clear in both the FAQs and the consent that they sign that these are FDA emergency approved test. The accuracy and we tell them what the accuracy is as listed by the manufacturer. We tell them not to use this as a diagnostic test. It is completely voluntary. And if results should bear questionable, it should be followed up with a PCR viral testing. So our lawyers have been very good about making sure that we kind of cover our bases.
Sure. Yeah, I know I worked with Tim to put your consent form together, and I joked with him that you're going to get an award for the world's most intense consent form this year. But in all seriousness, it was very thorough and very informative. So I think that's certainly critical. Anything to add to that, Amy or Tim?
I don't.
Another question around kind of employer responsibility when doing the testing is if you are required to report that to local or state health departments or to the CDC based on the results that you're seeing on your antibody screening.
We are
not at the moment.
Yeah, we're not required to, but especially in areas where we have quite a bit of positives, we are planning to report to the county where our refinery is, or on the pipeline, we'll report to the state.
Great, thank you. Another question on testing, sort of from the other side here. If an employee is tested outside of the employer's organization, and this may be a question for Amy, can the employer ask for a copy of those results or for the outcome of those results before they would return to work?
It's going to depend on where you're located. As I mentioned earlier, there are some governors who have issued directives saying employers are not required or are not permitted to require return to work authorization before employees can return. I mean, obviously the goal there is that we're not overwhelming an already overwhelmed, health system and healthcare providers with additional requests for documentation. So it is going to depend on where you're located. But as a general matter, assuming you have no, state or local directive, executive order saying you can't do that, then yes, you absolutely could require that information, a copy of those test results before allowing the return to work.
Okay, great. Yeah, another question from the group here on symptom monitoring. This might be a great one for Peter. Have you incorporated any PO2 values in addition to temperatures when taking employee screenings?
We've been studying that, especially after the really well-written New York Times article, from the emergency medicine physician. I think it's Dr. Levinson, but we have not incorporated that into our screening process at the current moment. There's a lot to think through, right? So you can, one is obviously we mentioned supply chain, got to get the post-ox. Two is, how do you disinfect the post-ox after every use? And three, we are not sure whether that, counts as more sort of, medical record, if you will, and how to store all that. In many ways with the temperature, I think more people are accepting of it, as Amy alluded to, and but we're not so sure on the post-ox side yet. So
sure.
One last piece is
changing every day. Yeah, exactly.
Yeah. Also have to think about what the cutoff is, right? So, based on the benchmarking work we've done, folks seem to think that right around 90, below 90, 92, may be a good cutoff. So I think CMS reimburses for supplemental oxygen below 90. Look, lots of variables to think through. But the short answer is we haven't incorporated that yet.
Okay, great. Thanks, Peter. Excellent question from the chat here that I'd love to throw in just one last one and across the board for the panel, for anyone who's dealt with this, is how are you combating misinformation that employees are encountering? Obviously social media and maybe less than desirable websites that they might be running into information that's just not clinically accurate or not accurate even of your organization. For the panel, how are you all tackling that misinformation that's floating around?
This is Peter. I'll contribute to this a little bit. So we realize that's a real issue. So we always have our communication teams involved in our decision making through the task force. But we've also they've helped us create a dedicated COVID-19 webpage so that our employees can go get very updated and real-time information that's already been vetted by our team. I mentioned that our CHRO is an incredible leader, and he actually hosts webinars, podcasts. Our chairman also sends out information alongside with our CHRO. We also have set up what we're calling the COVID assist line, where employees can call a number anywhere from around the world to a team that we are working with, who then can that's staffed by clinicians and can answer any COVID-related questions and provide education on this topic.
Okay, one final question from the panel or from our audience, and this one I know Peter actually brought up the importance of having good information technology, and this certainly goes out to anybody. But I know Tim and Dr. Parsons, you might talk a little bit about the value of having kind of a good IT platform in place, and the importance of being able to manage this on something more than a spreadsheet.
Oh, absolutely. I think and I told Emily and you this previously, that the cooperation that MIE has worked with Phillips 66 in building out the different types of encounters and reporting capability in order to provide our executive leadership team with daily metrics on how we're going with testing was completely invaluable. I mean, if we had to do this by hand, I'm also the supervisor of a 4-employee occupational health data team that's responsible for maintaining all of our employee records. And if we had to do this by hand, that's all they'd be doing for 8 hours a day, is trying to track this. Whereas now with the electronic system, and I didn't tell everyone earlier, but we were able to leverage the mobility system built into Enterprise to use iPads so that we can have, instead of having just a single or a series of exam rooms, each with a different computer system in there or laptop or whatever, we can just go room to room to room with an iPad. It's got the consent already loaded into there. It's got the entire encounter that you can pull up in there. And the mobility capability with that iPad is just amazing, and it's allowed us to become much more efficient. And then you guys built out, just to provide ourselves a little more legal protection, we have the capability to take a picture on that iPad, upload it directly into the encounter so that we have a picture of the cassette that's now embedded permanently into that individual's health record. So that if for some reason there is litigation, we have a picture of the actual test along with all the encounter information that we can produce to help protect the company. And if it wasn't for being able to leverage Enterprise Health to do it, it's like I told Emily last week, instead of actually performing testing, we'd still be here talking about how we're going to do testing. So, thank you.
Well, hey, unfortunately, we're not only out of time. We've gone over a little bit, which is great. But this has been an incredibly robust discussion and exchange of ideas. I really want to thank all of our panelists. So thank you, Peter Lee, Al Rielly, Tim Raycob, Bill Parsons, and Amy Adolay. I know you guys are all knee-deep in managing return to work. So we really appreciate your willingness to prepare and present and answer questions and share what you guys are doing at your organizations. It was very well done. Thanks also to Vic Isaac for monitoring our panel today and helping us facilitate some great dialogue. And thanks to all of you for attending today's session during what we know is a very, very busy and challenging time. As I said earlier, we'll be sending out a link to access a recording of the webinar early next week. So again, thank you. Have a great weekend. Stay safe and be well, everybody.
Thank you.
Thank you.
Thank you.